So we got done with your major connectors and the minor connectors. Next, it brings us to the remaining components, which are rests, direct retainers, and the indirect retainers. Now, these components are extremely vital to the success of your cast partial denture. The rests provide support, which basically prevents your prosthesis from sinking into the tissues, right? Your direct retainers are the parts of the cast partial denture that are responsible for retaining the denture in place and not getting thrown out of the mouth or falling in the presence of gravity and sticky foods. Your indirect retainers work to prevent tipping movements. The methodology by which they do that, we will be discussing when we look at the indirect retainers in detail. All right. So if you look at this what you see in the arrow, right, or the circle is your rest. Now it is basically a tongue-like projection of metal that sits into a specified preparation on the tooth known as the rest seat. So this is again similar to how a proximal plate and a guiding plane work. The proximal plate is a part of the cast partial denture. Similarly, the rest is a part of the cast partial denture. And like how we prepared the proximal surface of the tooth here, and that was called as a guiding plane. Similarly, a small triangular depression is prepared in the enamel of the tooth. That is known as the rest seat. So the rest seat is contoured to accommodate the rest within it. This will allow the CPD to sit and then load the teeth and thereby prevent sinking of the cast partial into the tissues when the patient is chewing. And this phenomenon is known as support. So in one word, your rests provide support for your cast partial denture. Right. Now, so what is support? It is the ability of the prosthesis to prevent vertical tissueward displacement. Right. So like I said, it prevents the CPD from sinking and impinging onto the tissues when the patient is using it. Now, the rest maintains a firm positive contact with the respective rest seat, right? And whenever the patient bites, it basically hangs on to the rest seat like a ledge and loads the teeth and the periodontal ligament and dissipates the force within the bone rather than the acrylic portion impinging on the soft tissues and causing trauma. That is how a rest seat work together and provide support for your partial. So the rest sits onto the rest seat, right? And it will prevent it from prevent the CPD from displacing further down. Now, the rest seat, like I told you, it is the part of the tooth that is prepared to receive the occlusal rest. Now, you can see in this particular scenario that multiple types of rest seats. So this is rest seat for an embrasure rest. This is an occlusal rest seat that's been prepared, right? And if you look at the canine, there is a Singulum rest seat that's been prepared. So based on what kind of rest you're going to be using, you can prepare different teeth at different locations to receive these kind of rests. And that preparation on the tooth is known as a rest seat, right? So like I told you, there are various kinds of rests. Based on the function, you can classify them as primary rests and secondary rests. Now, primary rests are usually associated with a clasp assembly, right? A clasp assembly is an occlusal rest or a rest associated with a particular direct retainer. So direct retainer plus rest gives you a clasp assembly, right? And this complex works together to both retain and to provide support for your cast partial denture. A secondary or an auxiliary rest may be given at other additional junctions, right? They can be provided to give extra support, and they can also serve the role of indirect retention, which we will be discussing later on. Now, based on the tooth, on what tooth you prepare, or based on where these are located, you can classify them as occlusal rests, which are basically prepared on the occlusal surface of the teeth. Right? Singulum rests, if it is going to be on an anterior tooth. You can prepare them on the incisal edge, also known as an incisal rest. Now, if you have a tooth that needs restorative treatment and you're going to prepare an onlay, instead of giving a traditional onlay and cementing it onto the tooth, you can design an onlay as part of a cast partial denture. Why not? The onlay is also metal. Your CPD is also metal. What says you can't prepare a wax pattern along with your cast partial denture and put it in place so that the onlay sits on the tooth at the same time the CPD sits on the tissues? That is possible as well. That is something known as an onlay rest, right? You have extended occlusal rest. Say, for example, you have a pre-existing large class 1 or a class 2 cavity. Then you can incorporate the metal so that it sits like an inlay along with the CPD into that particular tooth. And instead of a small triangular depression, you have a normal class 1 or class 2 class 2 cavity acting like a rest. So that is a on layer extended occlusal rest. And lastly, you have internal rests. Now, internal rests, we will be talking about them when we deal with attachments. It's a slightly later on topic, but just know that this is something like a class 2 box, right? A proximal box that has like a small metal box that is prefabricated and luted into that internal rest seat that has been prepared. Now into this box, and another metal piece will come and it will provide a degree of support. So that is what internal rest is. So I told you that it is the first type is going to be your occlusal rest. Right? It is prepared on the occlusal surface of your posterior teeth. So it could be from anywhere from your premolars to your molars. They are spoon shaped and the preparation should be confined only to your enamel. So this is very, very important. Your preparation of the occlusal rest should be confined to enamel. You should not dish too much and end up in dentin, then the patient is going to end up with sensitivity. Right? Now, in terms of the rest, there are very specific dimensions that you have to follow. These have been given in Stewart, right? Now, the angulation of your rest should always be at an acute angle. It should always be less than 90 degrees. This is because you want your rest to engage and hold it in, right? If you keep it at 90 degrees or at an obtuse angle, when the rest engages, there is a chance for the rest to slip and come off. You need a firm positive contact. Imagine you're trying to hold on to a cliff or a ledge. You want to curl around and hold. That is the same principle, right? So always at an acute angle or less than 90 degrees. And the depth of your rest should be 1.5 millimeters below your marginal ridge. So when you're preparing your rest, you should always make sure that you prepare or reduce the marginal ridge by at least 1.5 millimeters. Then additionally, you also have to take into consideration the width and the mesiodistal length of your receipt preparation. Now, in terms of buccolingual width, you have to take the intercuspal width, right? So you have the buccal cusp here, you have the lingual cusp here. You take the intercuspal width, and half of your intercuspal width should be the width of your rest seat. And if you take the entire mesiodistal width of the tooth, anywhere between half to one third of the mesiodistal width of the tooth can be the mesiodistal width of your receipt. Also, additionally, the deepest point of your receipt is 0.5 millimeters away from the apex, right, towards center of your receipt mesiodistally. So, in effect, if you look at in cross section, it will be a spoon-shaped rest, right, with a 0.5 millimeter thin margin here. The thickest portions would be in the middle, and of course, it continues into the proximal plate at this portion. This is what the cross section or cut section of a occlusal rest would look like. And these are the critical dimensions that you have to follow when you're contouring an occlusal rest and its respective rest seat. Next comes the cingulum rest. Now, I told you it is the same thing that is prepared in a canine on the lingual surface. The cingulum of the canine, especially the lower canines, automatically provides a recess. The anatomy itself provides a recess for you to prep the tooth to receive a cingulum rest. Right? It is a crescent shaped or a sad smiley shaped. And if you look at it in cut section, it is a V-shaped notch. Right? The preparation is done using an inverted cone burr, right? And it should be apical to the occlusal contact, because if you end up keeping it too close to the incisal edge, there might be interference from the opposing occlusion. It extends from the marginal ridge across the cingulum to the other side of the marginal ridge. Now these are your critical dimensions. It should be around 1.5 millimeters deep, right? 2.5 to 3 millimeters wide, and about 2 millimeters in buccolingual width. So these are your critical dimensions for your cingulum rest. Right? And this is what I meant. So it's look like a sad smiley and it has a V-shaped cut section. your incisal rest. So I told you that even you can prepare it on the incisal edge. Now this is usually not recommended because this is usually preferred when, say for example, you don't have canines and premolars and you have to end up using your incisors. The incisors by nature are one, labially tipped, and two, they are small teeth with tiny roots. So you really don't rely on them to provide a great degree of support. And that there are chances that if you don't contour your incisal receipt properly, and the patient is using the CPT, putting it in, removing it, there's a chance that this tiny shelf of enamel might break. All right, you might end up causing an inadvertent fracture of the tooth, which is not really preferred. So, coming to the incisal rest, it is used as a last resort. It is prepared with a flame-shaped diamond and should be about 1.5 to 2 millimeters deep, and it should always be 2 to 3 millimeters away from the line angle of the tooth that you are preparing it on. It should never be prepared at the angle itself, because then you will be leaving a lip of unsupported enamel which will fracture. So you should always stay up at least 2 to 3 millimeters from the line angles of your teeth, right? And when you're preparing it, you will always extend it slightly to the labial surface. So it is aesthetically compromised, but this slight labial extension of the rest is important because it will prevent a labial migration of the teeth. I already told you that your incisors usually have a labial tilt. So if you don't engage them properly, the pressure from the rest will cause the teeth to migrate labially even more. So therefore, you always have to extend the incisor rest preparation slightly to the labial surface. Now, these are just other rests. These don't have any critical dimensions given in the book, but I just wanted to show you for understanding sake. An extended occlusal rest, you can see that a modified class 2 has been incorporated into your partial, and an onlay rest. Basically, a portion of the occlusal surface itself has been restored and it is attached to your cast partial denture along with the clasp. All right. Now, this raises a question. If support is provided only by rests, then what about distal extension cases? Okay, anteriorly you have abutments. Posteriorly, you will have to end up taking support from the ridge or the tissues. So you have to use a degree of tissue support as well. So in distal extension cases, there is the phenomenon called as tooth tissue support. So in addition to the name saddle-based dentures or distal extension cases, the cases of class 1 and class 2 Kennedy are also called as tooth tissue supported partial dentures, right? Because they are going to take a degree of support from both the tooth as well as the tissue. Now, there are many factors that will determine how much load is shared between your tooth and your tissue. One obviously is going to be how many teeth are missing. The greater the span of the missing teeth, the more the forces that are going to be absorbed by the ridge and the remaining natural teeth. You can think of it something like Anti's law, right? More teeth are missing, then the remaining teeth will have to take up more load, right? Then, of course, you have the soft tissue support. What is the quality of the soft tissue? Whether it is a nice firm mucosa that is going to be able to take up the load, or whether it is thin mucosa that is going to end up getting ulcerated, what it is. What is the underlying bone quantity and quality? Whether this bone is going to get resorbed very much when the forces are applied, or it is going to be able to withstand that load and not resorb. And how well you are able to make the impressions and cover the anatomic areas properly. The better the coverage of your resin denture base is, the better you will be able to load the mucosa on the bone without traumatizing them, and better is going to be the overall tissue support that you can derive from these cases. What is going to be the anatomy of the denture base area? How well it is going to fit? The fabrication of a cast partial denture is actually a very technically challenging work, right? So if you have a good technician, you will have a good fit of the denture base, and you can expect your denture base to service the patient for a long time before you need to do some modification or repair to it. However, if the fit is not great, you might end up having to repeat, or in fact, the patient might not even be able to use the prosthesis. And finally, of course, the design of the prosthesis itself. How well you are able to place the components, how well you're able to contour the teeth, how well you're able to place retainers, how well, effectively are you able to use indirect retention, how well you're able to place the meshes in such a way that it aids in the future impression process. All these factors are also going to be factors that affect your tooth tissue support. Okay, now with that said and done, right, we are going to go ahead with direct retainers. So these are the components that are going to be holding on to the teeth and preventing your denture base from lifting away from your underlying tissues. Right. Now, don't get scared looking at this. It is just basically a classification of all the different direct retainers that are there. I just put everything together so that it's like a nice compilation, and you guys don't have to go searching elsewhere. Now, it is very easy, right? I told you direct retainers are things that are going to help in holding onto the teeth. Now, clasps, which you have been seeing so far in all these slides, are just one type of those. There's another thing called as an attachment, right? Now, again, attachments themselves might be within the tooth or it can be outside the tooth. Now, based on this, they have classified your direct retainers. Intracoronal, meaning within the tooth, and extracoronal, meaning outside the tooth, right? So intracoronal, when you come to intracoronal retainers, they are usually attachments. You cannot place a clasp within the tooth, right? You have to only be able to prepare something like a box or some kind of a frictional attachment. So all your intracoronal retainers, direct retainers, are going to be in the form of attachments. I'll be showing you attachments just in the next slide, so just hold on. Right. Now, you can further classify them as semi-precision and precision attachments. Now, if you look at the extracoronal type of retainers, also you will see attachments with the names precision and semi-precision. You just have to remember that precision attachments are factory made, right? They have a very tight tolerance in fit. They don't have much movement between them. And so it is like a lock slide joint, right? Hence the name precision attachment. They are very unforgiving and they don't have much movement between them. They lock in a very tight fashion. Whereas a semi-precision attachment is usually available in the form of patterns, which you will incorporate into the wax pattern and then cast it. So during the process of finishing and polishing, some degree of movement occurs, right? Or some degree of reduction of the metal occurs, which gives to a slight loosening of the fit. And moreover, you will use some kind of silicone or rubber elements that will provide some cushioning between the two attachments. So that is what is known as a semi-precision attachment, right? Now, in the extracoronal, meaning what is outside the tooth, again, I told you that there are attachments, but there are also clasps, right? Clasps, you have already been seeing pictures of those. They look similar to your orthodontic clasps that you do for your Holly's appliance and whatnot, but the difference being they are made of cast metal, meaning they are incorporated in the wax pattern. And whenever you burn out the wax pattern and you cast the metal into it, the molten metal itself flows and forms the clasp, right? Now, there is one very specific indication where you use your normal orthodontic wire to make a clasp. We will be discussing that as well. Don't get confused. But remember, in a cast partial denture, whenever you say cast clasp, you are talking about a clasp that has been formed by the lost wax process and the metal has flown and formed the clasp itself. Now, these can be further divided into roach or bar type clasps and circumferential or acres types clasps, right? In the acres type, you have multiple types known as embrasure, ronley, half and half, grasso, and you have a small subfamily called as the circumferential clasps, which have ring, circlet, combination, reverse circlet, and so on, right? So these are all the various types of clasps available, and these are all the different types of attachments that you might see. So all of these could be used for holding on to the teeth or the mucosa and retaining your denture base. Now, what is an attachment? I told you, I was telling you about precision, semi-precision. What is an attachment? It is basically a friction or a gasket type of system, right? You have a male component and a female component. Now, the male component is usually a projection of some sorts with a small undercut. So if you see here, right, you have a small projection here with a small undercut in this region. And you have a female component, which is basically a receptacle or a housing. Between the male and the female, you will have some kind of friction or a gasket type system. So this is basically a silicone gasket or a silicone retentive element. The idea is, once I cast this, I can attach it within the denture base. So you can see that this two-step housing is actually sitting inside here, right? And this male component has been attached to the 2-unit fixed partial denture or crown in this particular case. So you can see that this is attached here. And I can fix this silicone within the housing, and I can put it on top so that this slides on top and locks into place. This gasket will hold on to this small undercut and lock it in place. This is how an attachment works, right? Now, if it is going to be outside the tooth, as in this case, it is going to be a extracoronal type. Whereas if it is hidden within the contours of the tooth, as in so, it is going to be considered as an intracoronal type, right? Again, so your intracoronal retainer. So can you see this is submerged within the root itself, right? And in this case, you can see that this projection has been incorporated into the denture here. And when I put it on top of this and click it in place, it will go and sit into the root and lock. The attachments are made in such a way, right? So these are intracoronal retainers. Now, if they are factory made, as in this case, you have this steel box that locks into the steel slot. That is a precision type because it is metal and metal. Unlike the previous case where there is a small silicone gasket, you don't have anything here. Here it is metal to metal contact. So this is a precision type, whereas the gasket one was a semi-precision type. And based on whether it is outside the tooth or inside the tooth, it could be an extracoronal or intracoronal attachment. That is all that you need to know. So these are extracoronal. Like I told you, they are sitting outside the tooth, right? They are not within the contours of the tooth. All right. Now, so these are all the various types of your extracoronal attachments, right? You need to know the name. If you're able to know the features, then even brilliant, right? But then they all basically work by the friction lock mechanism. All right. Now, this is important for us. All the different types of clasps, right? Now, you have all the clasps are obviously going to be extracoronal. You cannot have an intracoronal clasp because there can't be a clasp running within the tooth, right? Doesn't make sense. So all your clasps are going to be extracoronal. Now, I told you there are two different types. You have your bar clasp and you have your Akers clasp or your suprabulge clasps. Now, just look at the names for now, right? These are all the different types of clasps that we're going to be seeing. But before that, you need to know how, in principle, clasping works. You might have studied about this in ortho as well, where you do wire bending, where you might be doing a C clasp or where you might be doing an Adams clasp, and you engage the undercut. Remember, you engage the cervical undercut or the mesiobuccal and the distobuccal undercuts. So how does this work? Right? What is the concept behind clasp retention? So first you will see what are the different types of the parts of the clasp, because this is necessary if you are to know how the clasp assembly is going to work. Now, of course, you're going to have a direct retainer, right? And the assembly I told you is consisting of a direct retainer, a proximal plate and a rest. If you look at this diagram, right? If you have something like this, the A is obviously going to be the occlusal rest, right? Your B is going to be your retentive arm. And what you see on the lingual side C is a reciprocal arm. Just know the names for now, right? The D is a proximal plate. So remember, the clasp assembly also has a proximal plate. The proximal plate actually forms the body of the clasp. So if you look at this, right? It forms the body of the clasp that is cross-hatched, this portion. And the gray, which are the areas from which the clasp arms originate, is called as the shoulder. So even though it is all structurally a single unit, just for the sake of understanding and for the sake of describing a clasp, they have been broken down into all these parts. All right. So an infrabulge clasp also has a similar structure. You have an approach arm that is extra that you do not see in a circumferential type, right? But of course, you have the proximal plate, you have the occlusal rest, you will have your retentive terminal, and so on. So these are the parts, right? Now, Prothero, he came up with this theory of a cone. According to him, if you take any tooth, it could be considered to be two triangles in which the bases are stuck to each other, and towards the root and towards the occlusal surface, the apex of the cones are present. If so, then the area where the two bases meet will have the maximal bulge, right? That area has the maximum circumference and is called as the bulge area or the area of maximal circumference. Now, in that area of maximal circumference, if you take any area below it and draw a perpendicular, then whatever is below will construe a undercut or an area in which the zone slopes away from the area of maximal bulge. So if this is the area of maximal bulge, then all this area that I've shaded is going to be in an undercut zone, right? And obviously, by the natural shape of the tooth, as you move cervically, the amount of undercut increases, right? Now, the idea behind clasp retention is that the retentive terminal, right, B, the clasp terminus or the retentive terminal will engage into the undercut. The rest of the clasp will be seated above it. And when you are having a force that is trying to remove the clasp, the force has to become greater than the amount of force that is necessary for the metal to flex, go past the undercut and get removed. So that is what Prothero's theory of cone is about, right? And it is the basis by which clasp retention works. So for a partial to be removed, the clasp has to be reversibly or elastically be deformed and slip out from the undercut so that the clasp partial might be removed. Now, since you know that, let us go into the basic structure or the basic design of the clasps themselves. So in your Akers or suprabulge type or occlusally approaching clasps, right? If you look at the name, Akers, of course, is one of the persons who popularized this. So this entire family of clasps is named after him. You might also see two terms known as suprabulge and occlusally approaching. Here, right, this is the maximal bulge area, right? So what they are trying to say is any part of the clasp that comes from above is considered as a suprabulge. Whereas if a clasp originates from below this bulge zone, it is known as an infrabulge clasp. So all your Akers type clasps, they originate from above the bulge area. All your bar type clasps, they originate from below the bulge area. And hence, all your Akers clasps are also called as suprabulge clasps, whereas all your bar type clasps are also known as infrabulge clasps. Also, occlusally approaching now makes sense because the bulge area is towards the occlusal surface. So since they are approaching from the occlusal surface, they are called occlusally approaching clasp, and bar type are called as gingivally approaching clasps. All right. Now, the first of these is a circumferential type. Right? Circumferential meaning hugging the tooth. They circumvent or they wrap around the circumference of the tooth and give clasp retention. In these, the circlet is one of the main types of clasps that we use. It is the most commonly used type of direct retainer in the extracoronal segment. Now, you also have the reverse circlet, the combination, multiple, fish hook or C clasp, right? Please not get confused with this C clasp and the ortho C clasp, right? Some of them also get confused between circumferential and C clasp. Please remember that in prosto, in clasp partials, the C clasp is a different name for the fish hook. This is a type of circumferential clasps which belongs to a family of the Akers clasp. You have the ring clasp, and in the non-circumferential Akers type, you have the embrasure clasp, onlay, half and half clasp, and finally the grasso clasp. It is completely okay if you don't remember all these names. Once you see the design, it becomes very, very easy to remember them because all of them, again, are related. They're just slight modifications of each other, just how your major connectors were there. All right. When you come to your circumferential, again, taking it apart, right, you have these types. Let's go into them. The simple circlet, right, most favorite, right, but you should make sure that you use it carefully. Now, like I told you, it approaches the retentive undercut from the edentulous space. It should not be used in distal extension cases. Why? Right? Can you see here in the distal extension area, they've used a bar clasp. It is coming from the gingiva and spreading out into a bar. Whereas here, they've used a circlet. Why is that? The reason being, this circlet clasp, it is going to grasp onto the tooth like an extraction forceps. And if you don't have proper bracing for that tooth, in like a distal extension case, this is free to move, the denture base is free to move. It is going to continuously rock the tooth and give an extraction like force. It's a class 1 lever effect, and it is going to periodontally end up compromising that tooth. And hence, a simple circlet clasp is not preferred in a distal extension case. But in all other cases, wherever the clasp is indicated, you will end up using the simple circlet. It is the most simple and one of the most effective designs in clasp retention. It is half round in cross section, meaning the surface towards the tooth is flat and the surface away from the tooth is curved. So it's like a round, you take a round and then you chop it in the middle and you put the flat surface against the tooth. That is the cross section of this clasp, and it flexes buccolingually. Right? It has to flex over the undercut and slip out. So that is a simple circlet clasp. So that's what you see there. Now, what is a reverse circlet? The reverse circlet is the same thing, but the difference being it approaches the undercut from the dentulous side. Right? So they say, what did they say? If you're going to approach the undercut from the edentulous side, then only it is going to grasp the tooth and give a rocking effect. They said, okay, why don't I do the ulta? I will approach it from the tooth side. So they named that the reverse circlet. Now, this is indicated in a distal extension case when the undercut is present near the distal extension case, right, or the distal extension area. It is basically a reverse of the circlet, and hence the name reverse circlet clasp. Now, this is a multiple circlet. It is simple that, it is a reverse circlet and it is joined at the reciprocal arm. Now, what you see on the lingual side of all these clasps, right? So, if you go back to the parts of your clasp very quickly, you will see that each clasp has a buccally placed arm, which is your retentive, and on the palatal side, you have a lingually placed arm that is known as your reciprocal arm, right? The reason being, these clasps will apply a force from the buccal when they are seating onto the tooth. If the force is unsupported, it will cause a palatal migration or a lingual migration of this tooth. So to counteract that effect, we provide a bracing arm or a stabilizing arm or a reciprocal arm. And that is the present on the lingual side. So this arm will prevent this undue migration of this particular abutment tooth, right? In a multiple circlet clasp, this reciprocal arm is joined on the lingual side. So in two adjacent teeth, you have two retentive terminals and you have a reciprocal arm on both the teeth that are joined together in the interdental area. So since it is connected on the lingual, it can be used to splint periodontally weakened teeth. Now, next is the ring clasp. This has a very, very specific indication in tipped molars. Now, you might see in long-standing cases of edentulism where, for example, the molars might have been extracted, say 6 as extracted, the 7 usually tends to drift in. In the lower arch, it is usually a mesial and lingual tilt, whereas in the upper, it is usually a mesial and a buccal tilt. Now, the ring clasp is specifically designed to counteract this problem. Now, particularly in this case, if you see, the red zone that you see is actually demarcating the undercut, right? So what they have done is there is a proximal plate here, right? Proximal plate here. And then from the proximal plate, the clasp emerges buccally, right? Cut.